Good evening from Hong Kong. Welcome to this online series of Asia Post-Pandemic Healthcare, organized by the Institute of Health Policy and Systems Research, where we have invited prominent healthcare researchers, academics, policy influencers, and also practitioners from Singapore, Taiwan, Japan, and Thailand to share their thoughts and views of how the healthcare system in Asia should move forward. What should be improved, changed, or given more emphasis? What should remain unchanged or kept strong? What should be dropped or dismissed? I'm Jeffrey Liu, founder and chairman emeritus of the Institute and host of this series. Co-hosting this evening's program, our inaugural episode, is Dr. S.K. Mak, who is vice chairman of the Institute and a practicing neurologist in Hong Kong. He's also vice president of the Hong Kong Medical Association and the immediate past president of the Hong Kong Public Doctors Association. Joining us tonight are Professors Kai Hong and Jeremy Lim from Singapore, who are expert advisors, researchers, and educators in health systems development and health economics. SK, Kai Hong, and Jeremy, do you want to say hi to our viewers?
Hi, everybody.
Hello, everyone. A very good evening to all of you.
Kai Hong and Jeremy, health systems across the world in the past decades seem to have made impressive gains to enhance people's health. But areas such as improving equity and access, costs and efficiency, quality and outcomes of care, governance and management, and institutional arrangements continue to remain clear struggles for many. In recent years, concepts of population health, big data, precision medicine, telemedicine, artificial intelligence, lifestyle enhancement, and non-institutional care are creeping in and taking root. Looking back on the development of healthcare in Asia in the past, say, 30 or 40 years, much progress has indeed been made. But with the disruptive impacts of COVID-19, it seems also evident that there is still much that needs to be done to enhance and protect people's health. What do you both see are the unique aspects of Asia's health systems and its most notable accomplishments? And what areas where clearly advances or improvements should still need to be made or worth making in the coming years? Kai Hong?
Over the last 30 or 40 years, as you can see, I've been researching and documenting and publishing many of these aspects of Asian health systems development and our notable achievements. So what you have seen in Asia, in particular our part of the world, East Asia, has been very rapid development. So along with this rapid social and economic development, we also have an improvement in the health systems among us, and especially among the little tigers or the little dragons. We have been constantly benchmarking ourselves and competing in a good way to upgrade our systems. So what you have seen in the region, what took place in the last 2 decades, was a phenomenon that took the West, Europe, a few centuries. So it's quite remarkable. So along with this success story, we also had a successful story to say about health system development and the very unique and very innovative ways in which we have delivered as well as financed and regulated our systems. So that's on the good side. Now, in its way too, we are constantly coming up with new challenges, and the latest now is the COVID-19. And WHO has also estimated that the new novel and diseases is going to come at a pace of about 1 or 2 a year. So we know that it's going to come, and our systems will have to respond to this. So can we sort of take on the lessons of the past? Yes and no, because we are innovative, we are responding to new challenges. So we are quite dynamic, and we have to show not just the way in which our systems can respond to many of these new challenges. So as we continue this debate and this discussion, I hope some of these lessons will surface. So over to you, Jeremy.
Thank you, Kai Hong. And Jeffrey, thank you for the kind invitation to share some thoughts. I would say Asian health systems have made remarkable progress over the last few decades. If we take the traditional axis of cost, quality, and access, I think what has been most remarkable has been the great expansion of access to healthcare. If we think back to doctors during the Cultural Revolution and how we have progressed to uplift people out of poverty and offer basic health services, not just in China, but throughout the entire Asian region, is a success story. Right? And in pocket countries, there are big healthcare institutions. There's AIMS in India. China has a number of outstanding hospitals in Hong Kong. We are achieving peaks of very comparable, if not surpassing, many of the Western hospitals, especially in Asian diseases such as liver disease, dengue, and really so on. So we have done really well on increasing access. We've done well in creating peaks of truly outstanding quality. Where we have done less well is in managing cost much more really cogently, and perhaps we have never had to struggle with cost management because our economies were booming. But now that we face the challenges of population aging and economic volatility, we do need to think about cost much more seriously and find the right balance on both demand and really supply side. And we live in COVID times, and I think Kai Hong has really articulated the fourth dimension that we must be very mindful about, which is resilience. And COVID has demonstrated here in Asia, as Ebola did in many African states not so long ago, that health systems may look quite attractive. But when faced with a severe shock, health systems can very rapidly crumble and be overwhelmed. And I think we in Asia need to be very mindful of this potential and build that surge capability. And then finally, I think the challenges that we live with are not just on the pandemic side, beyond COVID-19, what will come up, but many of us live in rapidly aging societies, and that sort of system nimbleness, the ability to pivot quickly to respond to new challenges, is something that we have to embed into all of our systems so that we're not reactive, we are proactive, and when unexpected things happen, we have the ability to move quickly. And it's not really, as really Deng Xiaoping describes, cross the river by feeling the stones. It would be ideal if we know where the stones are and we know which are the stones we want to step on as we cross the river, depending on how the currents evolve. And that's, so if I look at health systems across the 5 dimensions, cost, quality, access, that have added resilience as well as quality, these are the dimensions. We review the last decade's worth of achievements and those look forward into the future to see where we need to focus. And back to you, Jeffrey. Thank you.
Yeah.
Well, it's fascinating. I think you have captured very well, some of the changes and improvements we have been successfully able to deal with. In a way, there's a lot more that we can explore. I'll pass this on to Dr. Mack in just a minute. But I was, revisiting in my mind as you are talking and describing about the healthcare systems in Asia. In a way, I don't like this phrase because I think it has a rather different connotation when we say that. But in fact, we have done very well. I mean, between Hong Kong and Singapore, we have been ranked as the most efficient healthcare system in the world. With very little input relative to the output or outcome that we get in healthcare. But in a way, we're also the victim of our own success. I mean, our life expectancies, our infant mortality rate, some of the best in the world. I mean, it's not easy to understand how we can have accomplished that, but we have. But along with those, it caused us to catch up with the problems that some of the other countries are facing also. Cost of healthcare and the burden of illness, and particularly chronic illnesses, etc. I think it's fascinating. SK, what on to you?
Thank you, Professor Liu, and also Jeremy, and also Kai Hong. So for sharing. So people are saying, I think definitely the COVID-19 is got a severe blow to both of our local economy and also to our healthcare system. And I think now people is believing that we may need to living with the COVID virus for some time more. And I definitely that people counting this term as a new normal. So we may have to change our local practice, our habit, even our social activities to accommodate the upcoming kind of a new normal practice of living with the virus. So, but may I ask you what is in your mind when we are talking about this kind of a new normal concept that would hinder, or would it be an opportunity that for us to making our current healthcare system development faster, better than before? What would be in your mind? Do you think what before that, what should we define that the new normal healthcare system should be in the era of after the COVID-19?
Well, let me take a step at this. I mean, if you look back at the history of medicine and you look at a recent history of our region, there are a lot of things that we should be proud of. And so I'm not going to belittle that. But along with it, we have also created some problems, and we have not expected some of these new diseases, these novel diseases. But in some sense, it was expected. It was not a question of how, and what, but when it's going to come. It's going to come again, this disease acts. And so it could even be worse after COVID-19. So I think to look at some of the innovations, some of the resilience of people, and to look at how we have progressed, we can take a few lessons, can learn a few lessons from this. Of that is that we have to understand that human resilience will also adapt. The virus adapt, and we will also have to adapt along with it. So what was the new normal or new normal then had been changed to the way we have been behaving and responding. So primitive man without science, and now with the science, of course the pace is much faster. We have all the tools at our disposal. The question is, human behavior have not changed very much. I mean, are we doing all those things that our authorities have been telling us, and the evidence has been showing up, whether to put on masks or to practice social distancing or to have public health and hygiene, and it's becoming more and more difficult. You would say that with education and with rise in literacy and development, people would learn, but they do not learn, So constantly we are bombarded with these new viruses and germs all over. But the question of how societies and how governments are going to governize and to mobilize the respective populations and the societies to respond to this. But in many cases, a lot of the old diseases of poverty, of lack of development, had been solved in the sense when this part of the world became more and more affluent. So all the social determinants of health that was related to poor hygiene and the infectious diseases have declined. So in a way, creating this complacency that we have replaced them with chronic degenerative conditions and with aging. But now the double whammy is that with the aging of the problem comes the costs and how to take care of it. But at the same time, COVID, the virus, the clever virus, has also evolved to also affect the older populations. And the cost is going to be unequally shared among the poor, among the older age groups. So I think we will have to respond accordingly too. The healthcare system cannot go on as business as usual. The way we deliver, the way we finance must be responsive in order to be not only to address the inequity, the rising inequities with development, but also to be more sustainable. So I think it is a good thing for us all to come together now and re-examine many of these original hypotheses and then to come up with new ways or new options, alternatives to deal with the problem.
Yeah. Maybe SK, before I respond to your question about what the new normal looks like, can I go back to Jeffrey's comments about Hong Kong and Singapore and how we have achieved so much in the last few decades? I do think that two areas that both of our cities have done poorly. The first is in managing the politics around healthcare. And I think we just have not, despite the advances, we have not helped the populations to understand that it's ironically much easier to move from 1 to 6 than it is to move from 9 to 10. And so the trajectory that the population expects just continues to carry on in the same gradient, and that's just unrealistic. And I think that our political leaders have not managed this well at all. The second area where I think we have been too enthusiastic is in our fixation with letting the market run. And I am very struck that my insurance colleagues tell me that that insurance policies are now sold in 4 formats. There's global coverage, most expensive, then global coverage ex-US, not including the US, then next in line is Hong Kong, and then Singapore. And what these essentially signal to us is that both our cities are some of the highest cost destinations for healthcare. And the challenge for us is that we may have very high GDPs, we may have lots of billionaires, but our citizens are not uniformly wealthy. And something that's a couple of hundred Hong Kong dollars may be loose change to a wealthy person. It may be significant wages for a lower income person. And we have not managed that well, partly because of our ideological fixation with the role of the market and letting the market drive or determine a lot of how healthcare is financed as well as it is delivered. And I do hope that as we move into the new normal, we examine, as Kai Hong mentioned, some of these fundamentals. If you ask me what the new normal would look like, let me paint the optimistic scenario, then the pessimistic scenario. The optimistic scenario is that COVID-19 unleashes a new wave of social solidarity. We recognize that, like a chain, we're only as strong as the weakest link, and society moves out to not only look after the majority, but look after the weakest ones amongst us. And we then reorient our health systems to be resilient, to be adaptable, and to be much more equitable. The less optimistic or the pessimistic scenario is that we see a rise in the widening between the haves and the have-nots. The haves have the luxury to safe distance from the comfort of our own homes and live and work and earn a very decent living. The have-nots continue to carry out what we describe euphemistically as essential services, and they continue to put themselves at grave risk to disease, as well as earn pretty meager wages in exchange for the work that they do, and the social stratifications become worse. At the macro level, the pessimistic scenario is when countries or cities that have controlled COVID well, such as Hong Kong, such as Singapore, then form travel bubbles between us and other countries that have done well, and the poorer countries that have not done well are then excluded. And we not only have the haves and the have-nots within countries, within cities, but also across whole geographies. And I would submit to you that over the longer term, this is very, very bad for all of us in terms of global health security and also overall regional stability. So I am hopeful that we will think about the optimistic scenario and move towards that, but I think at this stage it's too early to tell.
Well, I think both of you mentioned something very substantial. I think it really deserves us to look into those, a lot more than just this, casual chat. But there are 3 things I think you mentioned that really capture, I think, or worth our further exploration.
Yes.
Jeremy, you mentioned that moving from 1 to 5, assuming the higher the number, the better it is. We have achieved something very quickly, something like that. Okay, well, maybe we were at 6 or 7. But moving from 6 or 7 to 8, 9, 10 is increasingly more difficult. Okay, let me ask the question. What were the reasons, what were the factors that drove us moving so fast from 1 to 5, 6, or 7? And what what's making it so hard for us from moving from 6 to 8 or 9? You mentioned some of these things, you know, in your scenario depiction of the future and the challenges they will.
It is really around, and I'll use the term Kai Hong used, the social determinants, and these tend to be environmental, they're external to us, right? And of course, this is also aligned to the epidemiologic transition that both our cities have gone through from the infectious disease to the predominant causes of death and burden of disease, the non-communicable diseases. So moving from 1 to 5 was really around strong government, public health and sanitation, and frankly, and I used to practice surgery. The joy of surgery is that even if your patient doesn't like you have removed the inflamed appendix or the gallbladder, the patients recover, right? But and if someone has got pneumonia, you treat with the right antibiotic, the patient recovers. But the world has become much more complex. Most of our citizens are dying from non-communicable disease, and the key to that is really behavior change. And we have not managed the behaviors or the solidarities in the last 20 years. And perhaps this notion around I can do anything I want, plus this kind of really unrealistic optimism that there is a technological fix. I mean, part of the reason why the US is in the COVID-19 mess that it is in is because the Americans tend to be exceptionalists and holding out that there'll be a vaccine and everything will be back to normal. They have had a precedent that has encouraged such almost magical thinking. And this then, this incentivizes people from the classic public health interventions that those of us who have lived through SARS are much more mindful of. And I think Hong Kong, Singapore, Vietnam have all very quickly masked, safe distancing, frequent hand washing, and we've done a lot better. So, and really that's why moving from 8 to 9, it's about behaviors and personal liberties, and that's a heck a lot harder than treating with antibiotics and cleaning up the water, the waterways and so on.
Well, can I just add to this? Since transitional theory has been invoked, you know, the different stages of transition, which resulted in a demographic transition and then the epidemiological transition, and so-called health transition, was initially done by the population scientists, and then the public health people came in. But as you observe society, it goes beyond the 3 levels of transition from high fertility and high mortality down to low fertility and low mortality. Now we're moving to the 4th and even the 5th or more stages of transition. For example, what's going to happen after you get an aged society and all the chronic diseases come in, and you end up with another age that the population scientists will say, we actually really don't know, because they're going to keep people alive on and on with better healthcare. But it's a very unequal situation because some people have it, some people don't have it. I mean, we all know that the transition that took place for over the course of development, it's a lesson that everybody learns, right? But it's very hard to practice, and half the world is still caught in that lack of water supply, lack of facilities, you know, whereas others are racing to the moon, you know. So we have this growing inequalities with development transition. What do you do? And behavioral change is not that easy, because how do you bring along everybody else? And provided the majority along with you to go to step 8 or 9. But even then, we have not solved the problems for half the world's population from 1 to 5, you know. So now we are talking about this going from 8 to 9 to 10 for a few of those. So I am actually a little bit more pessimistic rather than optimistic. On the one hand, we look at the successes, but we are all racing together to jump off the cliff, you know, in some sense. As long as we do not have a sustainable situation, as long as we do not learn to share the resources, this kind of disparate behavioral responses to all the challenges and the rapid pace of development is going to just drive us apart. So I'm afraid that one possibility in terms of scenario planning is a disaster for everybody, you know. But before we reach that stage, I think you probably have people in Hong Kong and Singapore still sitting on top of this heap, you know, but the rest of the rubbish dump is creeping upwards. So this analogy is such as that whether we look at it from a historical longitudinal perspective or cross-sectional perspective, the inequalities, whether it is within the country or between different parts of the world, between countries, I think it's growing, you know. So I don't know how, from a systems perspective, you're going to address this.
Well, let me come back to a question. Since we have a clinician here, Dr. Mack, I'd like to ask you for your reaction to this statement. I gather from what both of you have said, we have exploited the science and technology of healthcare very well. And that's why we're able to accomplish some significant improvements in terms of health. But we're confronting the future, or even now, issues that would need to go beyond science and technology. Is about people. And of course, accelerating all these improvements in the past would be the economic gains that we have throughout our region. But in the future, if we're going to have this poor and rich divide that Jeremy, you mentioned, you know, and also because of that, you know, the social determinants and the issues that affect healthcare would go beyond the science and technology of healthcare or clinical care. So, Dr. Mack, do you agree with this? I mean, in the past, we have significant gains, mainly from really good use of the science and technology. But in the future, we're moving beyond that, but really dealing with the difficult issues of human being and human being behavior.
I think, thank you, Professor. You know, I think what we are living are all in a very well-developed country. So actually, I echo that in our current healthcare system, we have a very good benchmark compared to other developing countries. So that our patient in general, well, we have the problem of the aging populations, and we also have a well-developed or a system that looking after people to give them very long life, and also we have a very developed social security system that help people to live in a protected environment, so that even by the end of their life. But the situation after COVID is that I'm thinking is the distribution of resources. So over the past 10 months, we all facing the situation of lockdown in the country, and also there's also a lockdown in our healthcare services delivery. So the one special thing about this virus is you notice that they have a particular high mortality rate for the elderly population. So I think most countries will try to suspend the elective services for the younger generations, but put on all their resources to look after the elderly patients in the hospital setting. So the problem after that is that most of our elective services, the waiting times, have been significantly longer, and even patients, the consultation. But I mean, the first consultation time when they have symptoms is also prolonged because of the lockdown of the services. So that's why I was asking the question about the new normal. So in the future, it seems that we are actually suffering from our our good deed there to help our aging population. We put a lot of resources to help our elderly patients, but well, it seems now over the 10 months that we have sacrificed our more productive class. I've been seeing patients, coming to the hospital with more advanced diseases, say, and in cancer patients, they have presented much delayed and have a more advanced stage. And also for some chronic illnesses like diabetics, hypertension patients, they have developed more complications before they are able to see the doctor, because they were afraid to go to the hospital for a visit, and they just want to postpone their follow-up consultation. So So is there, I just want to ask, as a frontline clinicians, is there any strategy, right, after the COVID-19 that we can better position our healthcare services? There's some public-private partnership program, or even some kind of a telemedicine monitoring program, or some innovative approaches that we can trigger on, so that, well, where we know that the virus may not go away for a short time. So in the near one, and in the near future, say 1 to 5 years, that we may expect the same the maybe fourth, the fifth, the sixth wave of the endemic will coming back. In that case, how are we going to position our hospital resources so that we are not jeopardizing the healthcare of the majority, the younger age group, but just putting on to the elderly population that were affected by the virus?
Let me take a step at this question. What happens after post-COVID? Because every society aims for greater efficiency and greater cost effectiveness in the system. Of course, some take 1 step forward and 2 steps back. But I think the silver lining on this COVID-19 issue has basically told a lot of governments and societies that you cannot neglect the infectious diseases, and there is always a communal or a collective method of financing it. And the good old-fashioned way is everybody have to pool the resources for the public good. So you can only do that to government involvement, the role of the state in collectivizing, your revenue and your services. So many of the responses are in a way directed by the state, through enforcement of the laws, through education, and to pooling your resources to whatever means. So I think the increasing collectivization cannot be replaced by all these liberal, individualized methods. Again, I think that's the first lesson that we have to learn, that infectious diseases and emerging and novel diseases will always be reviewed. So you cannot move on to a new type of public-private mix where increasingly you expect the market to come in and every person for themselves. I think there are certain collective things that you have to do together as a society, to meaningful things, whether it is to collective education or to share your resources. But then the debate becomes, how do you share? What kind of mechanisms of sharing? What kind of governments and what kind of healthcare financing and delivery system? I think this is the moot point now. But I think post-COVID, we realize that it is the collective responsibility, and more so, I would say the big P is in the public sector. A government will have to now mobilize their societies to tackle this on a collective basis. So we are rediscovering, in some sense, the role of public health, what it means to be able to get everybody together to follow the same page, and to behave in some ways to be responsible. Otherwise, you will pass on the problem to others. And how would a group tackle individuals who decide to do their own thing? I think you have to start off from that premise that the disease itself will provoke certain behavioral changes on an individual or a societal perspective, and then we'll lead on to the way we provide healthcare, then we lead on to the way we finance the healthcare. So what is an optimal mix in terms of the public or the individual, and how are we going to share, and how are you going to take personal and public responsibility so that the problem can be resolved? But it's not just COVID-19, because it's not COVID-19, it's something else, right? And you have to then look at the disease etiology, the different characteristics. But at this time now, we seem to be responding to infectious diseases, Right? But at another time, we are responding to other problems, whether it's rapid economic growth or it's a long process of meeting the needs of the aging problem. I think all these are now coming together at a much bigger and faster pace. So the more successful ones, the way I look at it now, if we are not going to die as dinosaurs in the ice age, I think the more dynamic one, the nimble ones, with the small society who can respond very quickly to make it a more sustainable and optimal mix. So I'll stop with this.
Before we go on, I do have a couple comments for questions for Jeremy, but I seem to get this sense that we have a big disconnect as a result of what has happened to us with the impact of COVID-19. I mean, this disconnect is also distrust between policymakers, governance, and also healthcare, science, and technology. Now, luckily, some populations are responding in perhaps more responsive ways to address the complications of COVID-19. Like in Hong Kong and in some of the other Asian countries, I think, the societal behavior as a whole is more applaudable, very good. But in some others, because of other issues, cultures, and perhaps political ideology and everything else, we're seeing a very different result of human behavior versus COVID-19. When we see human behavior, when we see this distrust, it's all about human beings. And I would couch that with the terms of governance and leadership. I think in healthcare, you would have not been able, in this particular instance with COVID-19, with leadership that can impact on government or societal, policies, as how to best integrate all the interests. I mean, at the end of the day, if we don't have good health, we're not going to have good economy, and not harmonious society. Jeremy, what are we going to do? Do you see the problems in that context at all? I mean, it's not about science and the technology. We have all the expertise that are available for us. Okay? The case mortality rate is not that bad.
I think
to have all these issues surrounding COVID-19.
I think the old saying that if you want shade today, you should have planted the tree 20 years ago really comes to mind. And I agree with you fully that it's not about the technologies or really what we understand we need to do. It's the willingness. It's the willingness on the part of the individual, and it's the willingness, as Kai Hong alluded to really subject one's individualism to the collective good. And people need to rally around trusted leadership. And where I think if we were to map COVID performance against metrics of governance and leadership, I would suspect that we would see that countries that have done better tend to be those countries that have invested in governance and in leadership for not just months before, but for decades prior to COVID. And so these countries enter into a crisis with more policy tools that can be mobilized because people trust the government. I mean, I really don't want to beat up on the US, but as someone who studied in the US, funded by the American people, I have a lot of affection for the US, and it's really so painful to see such a deeply polarized nation. And my hypothesis is that it is these polar behaviors that have been deliberately induced that is causing the US to have such a suboptimal response. And so I really come back to recognizing that health behaviors are really just a sliver of overall societal behaviors. So if we cannot get the societal attitudes, the societal behaviors aligned to the common good, then we should not be expecting individuals to then exhibit the appropriate health behaviors. So these just have to go hand in hand.
Right. Kai Hong, comments from you?
Yeah, I would say that from a comparative perspective, it does make a difference. I mean, when we are looking at the how we have performed and how different societies have coped with this new challenge, it's very, very clear the evidence is there. It's a question of what lenses or what do you agree, Of course, the social scientists will say, well, the communitarian societies seem to have done better. And even the governance models, those with women president and prime minister seem to have done much better than the male with all the egos and the macho responses. So, well, whatever it is, if you look at it, if you go into a systems perspective, what is very what impressed upon me is that we go to all those places that have all the top universities to learn their public health, which they teach us in theory what should be done, but they cannot practice it in their systems, you know. And so in countries where this is done diligently, you know, all those best practices of good governance as well as good public health are shown in countries that have got good governance. So you may have the best technologies and you may have the best systems, but whether you can pull it all together, you have to get the people in the system to pull together. I came from a seminar last week when we are talking about comparative governance. And this is based on empirical studies of someone who has studied the Central Asian systems, you know. And then in comparing it, you can actually tell the differences. The countries that are very authoritarian, you know, they have lockdown after lockdowns. Every time they have lockdown, you've got all the key performance indicators to show that COVID has dropped. But the moment you lift off the lockdown, in those totalitarian states, they come back. Now, in countries where it's polarized, it's the same phenomenon too. You know, some people are just going to go against it. If you're going to be tolerant and liberal, it's the same story. But the countries, they are sort of in between. They have, well, some of them will say, well, we're a little more compliant and obedient, but we are compliant with reason. You know, so if you have a good government who tells us all the evidence and we cope along with it, and you have a strong government that can enforce it, all the better, you know, until the crisis is over. But you have to juxtapose. It's not so easy now to just force it down people's throat because the totalitarian systems have also shown that it's not possible. You have to have that trust between government and your people. So I think the optimal mix is very important. With all the technology, with the way people's behavior, the optimal mix of governance, you know, in any system is critical.
You know, as we are talking about all these issues, it is easy to ignore a couple of things. Clinical care is individual. Health is a collective action. Now we're moving from individual successes now into collective success. I guess this is where, you know, moving from 6 to 8 or from 8 to 9 is increasingly more complicated. Now, I want to ask the question because we don't have too much time, but if we're going to move forward, I'll come back and ask, what should we uphold from what we've learned about the Asian health systems? But I think as we move forward, we must also be willing to let go of something, particularly those that have been inhibitors for us to move forward. Let me ask the question. What inhibitors should we drop? What things should we release from our social economic development so that we can enhance the health and give better protection to the health of people? What are the things that we must drop?
Okay. Maybe let me start the ball rolling. I think first we have to accept that markets generally are poor mechanisms to deal with pandemics and with severe shocks to the system. So we use the market and the market mechanisms when it makes sense, but we have to recognize when the markets fail. And I think COVID-19 has amply demonstrated that there are very significant failings if we depend too much on market forces. So we really need to find the right calibration. The second sacred cow I would slaughter is this artificial divide between the public and the private healthcare delivery systems. And I think here COVID-19 again shows all of us that every health system needs surge capacity. And it's very expensive to build hospitals and leave them unoccupied. And at least in these experience here in Singapore, that surge capacity came from the private sector, not just in terms of facilities, but in terms of nurses and doctors to do swabs, to look after the many migrant workers who were then affected. So the second sacred cow I would look at and slaughter with some relish would be this public-private divide. And the third one that that I guess maybe more unique here in Singapore is that we have traditionally discounted these so-called invisible populations, such as the migrant workers. And we've almost had our government agencies plan for the citizens and say foreigners, they have their own solution, and we're the Ministry of Health for Singapore. And I think COVID signals to us that that artificial divide just doesn't make sense, right? You have to be the Ministry of Health, you have to be the government for all peoples who are physically resident and every citizen and permanent resident who's outside Singapore. So some of these paradigms will need a lot of rework. And maybe the last thing that I'll say is that I do hope that the healthcare delivery system shifts away from this one size fits all. And I know that SK asked about delivery systems and how we have to change it. We have embraced during this short term telemedicine, and SK asked, is it telemedicine, remote monitoring, data science? I would argue it's really all of the above. And we need to almost think of the healthcare delivery system as comprising a set of tools and applying these tools at the individual level to what patients need. And here with COVID or any other pandemic, it's the one that got away that causes the major outbreaks. And we have to figure out how to cater to the last person and balance that risk. There's no point telling the old person, don't come to hospital because it's dangerous for you due to COVID. But as Dr. Mark pointed out, then the diabetes goes haywire, and we just have to start to balance risk and manage the risk and apply the right healthcare delivery tools to ensure the best individual outcome and align the individual outcome to the collective outcome. So those are the four sacred cows I would bring the scaffold to.
Thank you very much. I'd like to ask then, Kai Hong, you're a noted health economist. What do you think of the private sector, the market orientation in healthcare?
Well, if I take a health systems perspective, this is an audience for the Institute of Health Systems and Policy Research. If we are trying to achieve a systems equilibrium, a new balance has been sought, because with the disturbance or the disruption due to COVID, or for that matter, any kind of diseases that seems to create the surges or the problems, then a new way of responding has been there, new equilibrium. So that's the first response. So this micro statement of a whole of government approach has to go beyond the whole of society. It cannot just be the state, all the private sector or individuals doing it. So you have all of the above. Okay. Having said that, then how, which means that the devil is in the details. Of course, you cannot say, you cannot have a one size fit all. It has to be contextualized, and then it has to be appropriate and relevant to the situation, the stage of development. So which means that every society will have to come up with its own way of the optimal mix. And you cannot have things that have worked, then has not worked now, or not working, then you want to keep shifting and changing. But you must have a way in which all these responses are documented and then shared, and then you have to bring people on board. And somebody has to call the shots to where the new balance is, So in the area of financing, the way I have been thinking about it, it's no longer using a big mallet to solve the problem. When you are trying to get the social determinants of health, then government comes in to provide economic development and raise income and so on. So that has been very well taken care of, So now you have come to a much more complex issue where you have to decide what is public and what is private, what is collective and what is. So you have to then decide and prioritize that you can't do it for everybody and you can't do everything for everybody. So you basically will have to then decide what is in the public interest, what is collective, and what should be a private matter. So the public-private mix have to be quite well aligned and balanced, But the problem with many countries is that everybody is self-seeking. So the individual or the private sector may say, well, profit maximization is the way to go, and I will socialize my costs and privatize my benefits. So that's the problem now with a lot of society. So it's up to then the state and the people to come and say, okay, what is a proper public-private mix? And of course, don't forget the third sector, which is the voluntary sector. There will be a group of people who are not motivated by money, who are not being pushed by the state to want to deliver, and healthcare is full of that. So the public, private, and people sector, the state, the market, and the voluntary sector will have to come together. So how to achieve this optimal mix? I think that's the challenge of good governance. And having said that, those other kind of motherhood statements about, oh, greater equality to be achieved by the communist state, I mean, that's already passé, shown that it's not workable. At the same time, to just push it to the market for laissez-faire to get the optimal is also not possible. So we will have to intervene when it's appropriate, and we will have to say what is the right way of holding on, or the way to collectivize, and the way to take the personal responsibility. I think this optimum mix, to my mind, is very important, even as an economist, as we strive for optimization and greater efficiency and cost effectiveness. But having said that, I have my own personal preferences. I would say that if you look at the health sector, there's the difference between economics and health economics. And I would prefer to err on the side of caution to say the big P is very important. The big public sector is important. You still need the governance, but you will also need the other piece, of the private sector and also the people sector to get on board, you know. So so having said all this, you know, you have to get this equilibrium. It's not about everybody being equal, but it's everybody being equitable. The public, private, voluntary sector, the preventive, the curative, the rehabilitative, the primary healthcare, the secondary care, the tertiary care. So all have to be in balance. So maintaining and juggling this balance, I think, is the crux of the matter.
Of course, the essential question is, who is going to make determinations? What is the right mix? Okay, what are the best ways of getting to that right mix?
So you can't possibly run away from good governance and a good type of a system running for the society beyond the healthcare sector. So there will be some structure and functions involved. How are you going to decide as a society to either to the electoral system or to a capitalist system, the right balance between individual needs and a public responsibility? I think the form of government has been with us, intriguing us, you know, and we go from left to right and center, and we have tried so many different forms. I think it's a continuous process of human evolution.
Well, of course, I have been involved in health services management and leadership for all my life. And that's the area I know just a little bit. I have been increasingly disappointed in the ways we have developed people in those areas and the kind of competencies that we should excel in. I don't think we're there. We need a lot of work that needs to be done just so that we could be the ones that propose the best answers and influence, you know, the policy makers and the decision makers to buy in on our thoughts. But I think at this time, we cannot expect anybody else to tell us what the right mix is. And chances are it would be the wrong mix. And so we have the burden on ourselves to really be much better leaders and also governance in our own ways, to let other people be convinced that we could have the right answer. And we are the best master in terms of making that determination, moving from 8 to 9. From 9 to 10, let's leave it out first. I mean, moving to 9 is difficult enough. I mean, now, we don't have too much time. I want to pass the chair to SK, see if you have any questions. I do have, you know, a concluding question that I'd like to ask both of you a little bit later.
Well, so thank you very much. Actually, I think Professor Lim and also Professor Pan have been given a very comprehensive overview of what should be the scenario and everything after the COVID-19. So to conclude that in one sentence, so in the future, so what do you think that a COVID-19 vaccine will help? Well, will dramatically change the situation we are facing, or you won't believe it. But I mean, in just a short conclusion that is in your mind now.
Well, let me take a step at this because Singapore, as you know, is a co-chair with Switzerland in this new COVAX facility, an attempt to circumvent many of the attempts to have vaccine nationalism. You know, some free enterprise drug companies in the States are trying to capture this and to be able to make money from this. On the other hand, there are some countries like Russia and previously China were trying to use it for power, you know, to evolve their vaccine so they can give it to their preferred clients. But China has come on board, and I think we have been persuaded by especially the small countries and the more enlightened countries, the richer countries, to come together in the public good to decide what is a fair way of distributing vaccines when these become available. So it's currently, if you look at the COVAX facility, there is an agreement that those who can afford it will buy the agreement, including Singapore. And those who cannot afford it, like the poor countries, we will have to have an agreement that 20% of the priorities, that before the rich countries, through the wealth, are able to just swipe everything for themselves, before that happens, the 20% in the poor countries will also have to have their stake in it. So mainly it's healthcare workers and the most vulnerable. That means the old people with the chronic conditions, the multiple conditions, will first be served, you know, before you talk about the rest of the 80. But having said that, that's a very noble intention. But when there are so many candidates, you still have to go through the process. And from my public health, you have to evaluate it on the basis of not just the quality and the safety, but you also have to go through the stage 3 and the stage 4 before the mass production and to make it available. So the cost effectiveness will have to feature in. So right now, even when you're not talking about COVID-19, you're talking about just flu vaccines, there are already deaths and all that. So have this been properly evaluated for safety and quality? We have not even come to that. So how can we talk about efficiency and cost effectiveness? I think it's step by step, but COVID has actually pushed many of those issues now to the forefront. And it's not a bad thing, you know, for countries to respond this way and start thinking through now. How are we going to vaccinate our problem? How will we solve this problem? And then to serve the most people with the least use of resources, because there are also other priorities other than COVID.
Yeah. Okay, the good become better, the bad becomes worse. Okay, Jeremy.
I will give a very short response to the vaccine question because Kai Hong has mentioned quite a bit and we're short on time. I'll just say that given the likely efficacy and safety issues and the formidable task of around logistics, I think we should get used to wearing masks. Yeah. And back to you, Jeffrey.
Okay, well, let's close because we don't have too much time. I really feel bad. I wish we have, you know, half a day, a whole day, so that we chit chat, maybe over coffee next time to really explore these questions in depth. But let me, by the way of summing up, ask you both a simple question. If there are 2 or 3 things where future health systems in Asia should need to focus their attention, top attention, and in which to devote more resources, what would these 2 or 3 things or areas should be?
Well, I mentioned earlier on from the issue of efficiency and to seek greater cost effectiveness. So I'm maybe biased, but when you're talking about dollars and cents and financing, everybody seems to be an expert. So the question then is in the allocative efficiency, to get greater allocative efficiency, you know, and to get greater technical efficiency, you have to talk about resource allocation. So you have to solve that. So I think COVID has basically pushed us, what are essential necessary things to be collectivized, right? And keep it at that, the role of the state and the role of government. Now, above and beyond that, the nice things to have, the private sector can come in to complement it, but please also be assured that there are certain goals and incentive structures that's built into it. So when we're talking about the type of financing, of course, you have to look at the history and the evolution of what is possible. You know, for us in Singapore, we basically look at financing from the different stages of growth, right? When public financing through taxation was the way to solve many of those public health problems, that was the way. But increasingly, when we move into a public-private mix, then the cost becomes more costly. Then you have to protect certain people. So the insurance component comes in for cost sharing, and the prepayment that comes in. But a third factor, which Singapore has almost jumped the gun, was to push the savings component, because with the rapid aging, we say that every generation must be able to put aside the money to save. So for the rainy day, then we bring back the savings. So we have done that on the collective basis, on the macro basis, with the government's investment funds, and which we are bringing back now. 5 revisions on the budgets, and we have done that very well. But on an individual basis, we seem to be a bit confused. What is savings and what is insurance and what is taxation? We have mixed it all up. What is convenient? So we are trying to get all the money from all the different sources now to bail us out from this crisis. That's a very dangerous precedence, because from my scientific economic rationale is that you have to use what is right for the moment. For example, taxation for collectivizing, for income redistribution, use taxation. If you're going to use insurance, use it for risk pooling. What is insurable? So things that are not insurable by the private insurance, don't, for goodness sake, go and use insurance to cover it. And we are now trying to even justify using our savings, our hard-earned savings, to bring it into, to save the government's sort of pence, in a way. So that to me is fundamentally wrong, and we have to fight very hard to say that that money was preserved for savings. Please use it for saving. If you have to get into some alternative financing like budget deficits and so on, government gets into deficit, that's fine. So when it's good time again, then balance your budget again. So use your financing appropriately, but don't mix it all up what is convenient. To my mind, it's actually even more difficult when certain people who are losing money now are trying to justify getting the money, and they'll use all sorts of excuse, whether it's social insurance or savings or whatever. And like I said, these are individuals who are losing their businesses and therefore are trying to justify using other people's money for their own cause. So that, to me, you have to be exposed, have to be discussed by everybody. So you have to have a type of financing where government must consult the people, and you must have a collective way of where the mix is.
Absolutely. You talk about allocative efficiency. That's very difficult to accomplish, of course, in this complex world. And the second thing is, I think you're talking about maybe technical efficiency of the health system. How do you generate productivity, mobilizing resources, for example, in the private sector for the benefit of the population health? That's not easy either. But I think those are two very important issues. Jeremy?
If you ask me for 2 things, I would move even more upstream, and I would focus on building data systems so that we can make these rational decisions that Kai Hong had spoken about. SK earlier referred to the notion of excess mortality, whether COVID-related or non-COVID related. And the reality is that for countries that don't track these, we're just flying blind. We don't know whether we should do A or whether we should do B. So building up the data systems, not just the technology, but the political will to see these through would be, to me, an absolute imperative. The second thing I would build is trust, because behavior is so much related to trust and willingness to know that someone knows better. And I'm mindful of this folksy quote that people don't care how much you know until they know how much you care. And so building data systems and building trust, to me, would be 2 of the highest priorities moving into a post-COVID world. Back to you, Jeffrey. Thank you.
Okay, thank you very much. SK, any follow-up question from you? Quick one? No, okay. Well, thank you very much, Kai Hong and also Jeremy, for sharing your vision of what our future health systems should encompass and how we should seek to develop more effective and responsive healthcare in Asia in the coming decades or years. Good night, and see you at our next episode, where we'll have our expert friends from Taiwan to talk about Asia's future healthcare. Until then, stay healthy and safe. Good night.
Good night, everyone. Thank you.
Thank you.